All right, well, welcome back to this keynote portion of our 2021 Maryland State of Reform Health Policy Conference. I'm super excited to be with our afternoon group, and as folks are coming in and finding their metaphorical chairs and getting ready for our show here in the afternoon, I think it's always useful to reflect on so much of what we hear about at these conferences. I get the chance to drop in and listen to a lot of them, and of course you do too, because you can come and go and just like walking from one room to another at a convention center, you can click in and out of sessions, and there's just really good energy, right? I mean, there's good positive energy about we're coming through COVID, knock on something that resembles wood, and summer's out and people are feeling hopeful, and it's just useful in a time, I think, of ongoing challenges to reflect on when things feel good, we should herald it. And boy, it has felt good today. So this is a great way to end a good day with a great conversation about health equity in Maryland. And I'm super excited and honored to invite to our metaphorical stage here four of Maryland's most thoughtful and most active leaders in the healthcare space. First, we have Dr. Letitia Dzirasa, the commissioner at the City Health Department in Baltimore City. We've got Brian Pieninck, the CEO, I'm going to screw all of these up, the CEO and president of CareFirst BlueCross BlueSheild. Dr. Mohan Suntha, the president and CEO at UMS, or the University of Maryland Medical System, and the inimitable delegate Joseline Peña-Melnyk from the vice chair of the House Health and Government Operations Committee. I try to do all that by memory. I should never do it. I should just read the piece of paper. It'd be easier for everybody. Delegate Peña-Melnyk, I'm going to refer to everybody by their first name. So Joseline, tell us first about what it's like being a few weeks removed from the session, and particularly how health equity played out in the 2021 session. Now that you're through it and you can kind of reflect on it, how was health equity talked about in this session?
Well, I have to say, and thank you, and Joseline is fine. Thank you so much for having me. It's really an honor to be with this amazing panel. So thank you for the opportunity. I would say that this session, public health was a winner. And it was a winner because everything aligned perfectly. As you know, the disparities that we learned from COVID were really distressing. We know that Prince George's County have the highest number of COVID-19 cases in the entire state. We also learned that the zip code 20783 is the zip code with the highest number of cases in the entire state. And that's also in Prince George's, but it's also the immigrant Latino community. So we knew there were health disparities, but to the extent that we learned the data when it came in, it was alarming. So we focused this session, particularly in our health committee, on bills to address the health disparities in the state of Maryland. And we passed bills, to preserve telehealth access. I put in a bill that actually requires implicit bias training for all healthcare providers in the state of Maryland. Also, the House Bill 78, which is the Shirley and Pulliam Health Equity Act. When you ask about what did we do this session regarding COVID, the health disparities, public health, this is an important bill because it declares racism as a public health crisis in the state of Maryland. And that's very important because you must first acknowledge that to be able to deal with the problems. And it actually is a commission that is going to be in state government that will bring all the different departments and secretaries, like the Department of Transportation, Education, Department of Health, right? The environment, bring them together at least 4 times a year to look at their policies with a health equity frame, right? We have never discussed that before, in Maryland. This is something that is now going to be part of every policy that these departments develop. We also passed House Bill 309, which it's a data requires the collection of data, race and ethnicity information, which is so important because the science needs to guide the public health policy. So to go back to your initial question, we focus big time on public health. The General Assembly did, and the Speaker actually had a Black agenda, a Black and Brown agenda, and these bills were part of that. So we did a lot of work. We will continue to do a lot of work because we have a lot of health disparities in Maryland. And it's very sad because the Black and Brown communities have been hit the hardest in our state due to COVID.
So Letitia, as Joseline says, there was this lens about diversity and equity in the legislative session this year. As you were leading the public health response in Baltimore City and working with other health officials and thinking forward to this time where we're now vaccinating folks, how did that lens play out in your work, particularly related to vaccinations in Baltimore City?
For sure. Well, DJ, thanks again for the invitation, and I really am honored to be on a panel with such esteemed guests. I also want to just start by shouting out my guests. I want to thank Joseline for all of the work that she did at the state level to pass legislation that is equity centric. And I also want to thank Mohan and thank Brian. The city very early on formed what we called a public-private partnership. So it was City of Baltimore, CareFirst, University of Maryland Medical System, and Johns Hopkins Health System. And I bring that up because I think that's been so important to a lot of the work that we've been able to do. So we started off, it's a part of our mission. We started off with a lens of equity, right? As we were seeing the disparities in real time, that helped to guide where we put our mobile testing units, right? So we looked specifically at zip codes that had been most impacted, that had the highest new case rates, that had the lowest access to care. And that's where we would go and implant our mobile testing sites. And we've really employed the same strategy with our vaccination efforts. So while we did establish a mass vaccination site on the western side of the city, we also established mobile vaccination teams at the same time in partnership with hospitals and in partnership with pharmacies. And our mobile vaccination teams have really looked at senior housing sites first, and we're now transitioning to looking at our zip codes with the lowest vaccination rates, as well as the highest new case rates as we make decisions on where our pop-ups will be. So that senior housing focus did the same thing. We were going to senior housing sites, and as much as we were seeing the disparities, when you look at some of the overall vaccination rates, oftentimes for the data that we collected for some of our senior housing sites, up to 80% of those vaccinated would be African American, because we were so intentional about going to those places where we knew they had been hardest hit first.
Wow. So Brian, one of the nice things that plans have is data, and certainly statewide data across lines of business. As you at CareFirst and your team at CareFirst were sort of entering into the pandemic, and then the whole pandemic, pre-vaccination and after vaccinations started, how did you see the data start to tell this story about challenges to health equity? What started to pop, and then how was CareFirst able to respond as you started to see that data form?
Yeah, absolutely. And I want to start where Dr. Dzirasa started. Thrilled to see this particular group of folks who I know are personally invested in health equity and the health of all of the people of Maryland, and certainly organizations and individuals that we've partnered with in the past and will continue to partner with in the future. These are conversations we've had. I think one of the things that we need to confront as a healthcare system is that we do not always and do not currently have all of the data that we want and will ultimately need to be as effective as we're going to want to be, need to be on behalf of our communities as it relates to health equity. Too often, race and ethnicity data is missing, social data is missing, language data is missing. And so important to recognize that building durable solutions, products, services, analytical models that meet the needs of people have to include who people are, where they're coming from, what are the social and environmental factors that influence their health and their well-being. And so I think this has been, frankly, an urgent wake-up call for the entire industry. And this isn't just limited to what we're seeing in Maryland, but it's all across healthcare and health policy making, in really beginning to round out our perspective of people and how to care for people. And so we made investments, not just in assessing what we had available to us as it related to clinical data and public health data, but also social determinants data from outside sources, partnering. Mohan and I actually launched a partnership to address the needs of Medicaid populations in Maryland in the midst of this pandemic, beyond the work that we were doing together as part of the public-private partnership with the city of Baltimore. And all of those conversations conversations, one of the most urgent things we talked about was making data-driven decisions. And so I'll just share a few things with you, and in the spirit of hope and that we're not alone. Nationally, COVID-19 mortality rates are nearly 2 to 2.5 times higher for Black, Latino, and American Indian or Alaska Native Americans than non-Hispanic whites in this country, 2 to 2.5 times. So this is a challenge or a story that's been written across the U.S. healthcare system, not just the Maryland healthcare system. And we see similar dynamics here locally. Black residents represent 30% of Maryland's total population, but 35% of COVID deaths and only 24% of COVID vaccinations. Hispanic residents represent 11% of Maryland's total population, but 15% of COVID cases and only 7% of COVID vaccinations. So a lot of work and time and energy has gone into this, but there has been a large magnifying glass that has been dropped on top of the U.S. healthcare system, the Maryland healthcare system, and what it has revealed is systemic inequities. And so our hope, I believe, collectively and individually as we bring this work forward, is that we not unsee that, we not unknow that, and that we begin to collect the data we need, build the relationships we need to act on this with urgency. And so I think that's a bit of where we are and where I hope we're headed next through this discussion.
So Mohan, I know, sometimes the tyranny of the right now, and certainly in a public health crisis, there is a tyranny of the right now. Sometimes that crowds out the ability to be forward-looking and more proactive rather than reactive. But as you sort of reflect on these lessons of the last 14, 15 months and how it's impacted the hospital system, how are you kind of changing or recalibrating your vision for the rest of 2021, maybe into 2022 and 2023, to take these lessons from health equity and apply them moving forward?
Yeah, so thanks, DJ. And again, thank you to my colleagues on this panel. You've heard this word and you're going to hear it throughout this conversation, and that is the word of partnership. And folks who are on this call have truly answered the call in terms of the partnerships that we've all collectively forged to recognize, in recognition of the fact that to solve the challenges that we are collectively facing, the only way forward is to do it together. And I think Brian and Letitia and Joseline have all described examples of where we've been able to advance our thinking, advance our approaches to dealing with this pandemic as a consequence of doing it together. And so, when I think about the lessons learned for us as a health system, we have the blessing of having an obligation of delivering healthcare to a dramatic part of the state of Maryland. We deliver approximately 25% of all hospital-based healthcare through a vast diversity of geographies and communities across the state of Maryland. And with that, one of our early lessons learned from our response to the pandemic is the coordinated approach to think and act like a health system, and then to externally look for partners, was the single best approach to dealing with the challenges that we faced early on. When we think about our go forward, there is no question that our lessons learned are largely going to help shape the future of how we think and act like a health system. We were fond of saying early on that what we do, how we do it, when we address the issues that you've heard others talk about around the issues of health equity, the issues of equity and social justice, no matter what we did, we were shaping the culture of who we are as an organization. And so we chose to very early on lean into the challenges that COVID laid bare when it comes to healthcare disparities, lead into the challenges of equity and social justice, and define, and in doing so, we believe that what we are doing is laying the foundation of the culture of who we are as an organization that will survive well past COVID and will actually help drive who we are as an organization and how we define ourselves as anchor institutions in our communities going forward.
And Mohan, I should say to you, as a representative of the Maryland Hospital Association, I thank you for being a sponsor of this event. I really appreciate it. Of course, to Brian, also to CareFirst, the wind in our sails that you guys put is what makes all of this happen. I want to ask another question of you, Mohan. This comes from Dr. Nicole Rochester from our audience. She asked specifically about how how do we ensure accountability, she asks, for disparate health outcomes in healthcare facilities and medical practices throughout the state? So how would you recommend that the community or policymakers hold the healthcare system accountable when it comes to ensuring equitable health outcomes?
Well, so I think, and I think it was Brian who mentioned this, right? So, and Joseline, in that COVID laid bare the truth about healthcare disparities for our nation. And I think what we have to understand is some of those truths absolutely are, as Brian described, measurable realities. So measurable, I think folks getting in rooms and agreeing what are the deliverables and the measurable outcomes that we would hold ourselves accountable to, and the standards by which we say access and availability to healthcare, and then the equitable delivery of care. So once access is achieved, the equitable delivery of care, and then measuring outcomes that again take into account the factors like social determinants of health, et cetera. I think part of what we have to do is get far more transparent with our data and our performance. And I would argue that in the state of Maryland, we as a state, as a healthcare industry, have gone further and faster in many regards than the rest of the nation, in part as a consequence of the uniqueness of our reimbursement system, and that has allowed for a higher level of both accountability and transparency of performance. I think the job that's in front of us is to actually lay out those metrics that we would say we've recognized for a long time, and now to the questioner, now the accountability that comes with the transparency of that performance and data. I think as an industry, we have to be willing to lean into those conversations with partners like the folks that you have on this call.
Yeah, so, DJ, I'd love to jump in on that, and I think just in the spirit of partnership, because Mohan and I will just share, have had this conversation both publicly and privately on more than one occasion, and this idea of making data-driven decisions and forming data-driven partnerships. And what I would say, and what I know he believes is, it starts by understanding that our zip code is a greater determining factor in our health and well-being than our genetic code. There are places in this state where you can cross the street and statistically lose 10 years on your life expectancy. And fostering a belief that quality of life shouldn't depend on the color of our skin or the neighborhoods we live in. And so for us, we imagine coming together, right? We've talked about public and private partnerships, and we've seen the effect of that. Imagine if we could do for health equity what we have done for COVID. It has been a monumental undertaking. It has been an incredible integration of resources from all across the public and private sector, but it takes that kind of effort to change the trajectory of nearly 20% of this country's GDP. It takes all of us pulling in the same direction with transparency and clarity, not just of data, but objective, working together and figuring out how we can best contribute. The other thing I would say is that it's critical to recognize that an equitable system is a value-based system that focuses on quality and outcomes. Our current system needs to move away from volume-based fee-for-service care to focus on positive and lasting health outcomes for people and the communities that they live in. And so value-based care is targeting long-standing weaknesses. We saw the limitations of the transacting of care through COVID and how that exacerbated things like access and affordability. We need to get to this orientation where we're thinking about the whole person through all phases and facets of life, move with them in a relevant and appropriate way, and think about health as a broader proposition than just giving care, right? It's about how we tend to individual needs and community needs in a much broader, socially minded way. And so I think these are the kinds of investments that can only be made when you bring to bear the full heft of every participant in the healthcare system, hospital systems like that of Mohan's, public entities like the city of Baltimore, the state of Maryland, working together in conjunction with organizations like CareFirst and beyond.
So Joseline, how does state policy making fit in here? As a citizen legislator, sometimes it's super hard to know top from bottom in the complex world of healthcare. You're the vice chair of the Health and Government Operations Committee in the House. How do you think of the legislature's role in this question of holding the healthcare system accountable broadly for issues related to health equity? Joseline, do you?
It's all related. It's all related, and we do that. We do that every day. So when I was discussing the House Bill 78, which is the Public Health Maryland Commission on Health Equity, the Shirley Nathan Pulliam Health Equity Act, for example, is one that does that. Because it establishes a commission on health equity that would employ a health equity framework, right? And it says very specifically that this commission must provide advice on issues of racial, ethnic, cultural, and socioeconomic health disparities. But it also says that it must provide advice on issues, for example, that affect the communities of color, that it must develop a comprehensive health equity plan to address the social determinants of health, right? It must set goals for health equity and prepare a plan for the state to achieve, health equity in the entire state, and look at all the different systems. So it is a way of a check and balance for us to know what the data tells us, to know who's doing what, who's not doing what they're supposed to do. And that includes the hospital, it includes the doctors in private practices, it includes every healthcare provider. And it requires a report to be given to the General Assembly annually so that we know what's working and not working. So everything is related, we all work together, and the General Assembly is actually kept informed of everything that's going on in every system, which is why you see that we do react with certain bills, right? Every bill that when we're in session, January to April, all those bills come from people like the ones you have on this panel, right? They come from citizens, they come from advocates, from nonprofits, so that we can fix what's not working and improve, the health of every Marylander.
Letitia, I wonder if you'll respond. If you want to respond to Joseline, go ahead.
I had a thought, actually, and this maybe goes back to what Brian and Mohan were talking about, right? I would add, and agree with everything they said, I would add the importance of wraparound and support services, right? We've seen throughout the pandemic, many people going to work when they were ill because they couldn't afford to take time off or they didn't have benefits set up. So while yes, there are responsibilities that the health department has, that our healthcare systems have, I think there's also this kind of larger responsibility of providing, those wraparound and support services. And that's a collective effort, right? So that's going to encompass our community-based organization, our faith-based organizations, as well as additional funding, whether it be from the local, city, or state or federal level. So we really do, as Joseline, I think, has mentioned, have to think more broadly about our policy, right? And health equity isn't just achieved by ensuring everyone has insurance, right? Health equity is also achieved by ensuring that they have access to job and training and transportation and grocery stores.
Yeah,
and
so
if I may just add briefly, and all of you on this panel helped with this bill. It was I believe it was House Bill 463 that established the Maryland Health Equity Resource Act to help establish the Health Equity Resource Community, the HERCs, right? Which is going to target specific resources or specific areas in the state of Maryland where we have health disparities, right? And the bill actually sets aside money to be able to have exactly to do what you just described. Money, to bring back into the community to address and promote primary care, for example, prevention services, reduce healthcare costs and hospital admissions and readmissions, to work in certain communities that are suffering from these health disparities. And we know that they stem from the social determinants of health. What Mohan was describing, it is the way people live. It is basically lack of transportation, lack of education. It is the environment. And we learned from COVID that a lot of these people, mostly Black and brown people, were essential workers as well, right? Make very little money. They live in poverty. I know I was doing food distribution for families that were 9, 10 family members living in a 2-bedroom apartment that were all COVID positive. I mean, that is the reality that we have.
Yeah.
So I think it really does speak to when we talk about anchor institutions and what the obligations are associated with being anchor institutions. It really is thinking and acting and getting outside the walls of our organizations and getting upstream in our communities to, as Letitia talked about and Joseline just did, how is it that we have the ability to impact? through our actions, through our investments, through our partnerships, those social determinants of health. And when you think again about lessons learned from COVID, when you talk about trying to get upstream, vaccination is a phenomenal example in my mind of how you get upstream to impact future health, right? And that takes effort, it takes meeting people where they are, it takes education, and it takes constant conversation and building of trust. It doesn't just happen as a consequence of saying we're here and we're here to help. It happens because your voice becomes a trusted voice.
Yeah, I couldn't agree more. And when I look back on the public-private partnership at the outset of COVID, and we talked about readiness and response and recovery, and the work groups that were formed, if you really to break down those work groups, the majority of what we were doing was more of a logistical challenge. We were dealing with things related to communication and transportation. It wasn't all explicitly healthcare. And I think just to tie this back to the conversation, DJ, that we had earlier about data, we know we can quantify approximately 80% of an individual's health is related to social determinants of health, including housing, food, employment, and safety. And so when you look at these things, and we met earlier, we're kicking off our annual United Way campaign. We had this conversation with the folks at the United Way. Is digital divide, is that healthcare? Yes, it's healthcare. Access to information, safety, jobs, training, all of these things contribute to and ultimately determine the trajectory of a human being's life that can be quantified in terms of health, manifestation of disease, chronicity over time. And so I think this idea of expanding the definition when we talk about public-private partnership, as well as where we're looking to intervene, is a critical part of the solution, and also begs that beyond the people that are part of this panel, we need every single person in the audience to be pulling in the same direction with us, because that's what it's going to take. It's going to take a community effort. When
we get momentum like we got, I want to stay out of the way and let it roll. I also want to stop and jump in and make sure some of the voices of our audience can be part of this mix. And Brian Sims has a question that I'll ask you to speak to, Letitia, because I think you have a little bit of a cross-silo perspective. You all have a cross-silo perspective, but he says, I find that the bulk of these conversations are often and repeatedly held among evangelists or leaders in this space, those addressing disparities and inequities. How do we identify those who are slower to adopt steps for systemic change, or maybe resistant to the notion of inequities and disparities, and bring them along? I wonder if you have any thoughts on how to bring along laggards who are not maybe working towards systems change on this topic.
Yeah, I think you've probably heard all of us at different points mention the data, right? And in my opinion, and I'm a data person, right? I think the data speaks for itself, right? We've seen locally the disparities among African Americans and Blacks when we think about, infection rates, for instance. At one point, the Latinx community accounted for 15% of the case rates in Baltimore City. They account for 5% of the population, right? We're seeing the disparities now with vaccination rates, right? Where in Baltimore City, that's 60% Black. We have African Americans, as far as the total percentage that are vaccinated, about 20% lower, 20 percentage points lower than that of whites in the city, right? So in my opinion, and again, I'm a data person, the data speaks for itself. I think you can look at the CDC's website and see the national trends in data. They've released a lot of papers about it. So I would hope that people would look at the data and really see the differences and disparities in the data when you're trying to make that argument for someone who's not on board.
Mohan, I want to ask you another question, this one from Larry McNeely. He asks, how does the health system collectively deploy more high-touch community health workers or peer support or health ambassador models to attack health inequity in both rural and urban and suburban zip codes? How do we sort of get those mid-level or community-minded providers out to engage on these topics of inequity?
So again, I think it's kind of taking the lessons we're learning through our COVID experience. And so, if, mobile vax is an example, but how we engage in community-based testing, how we identify our highest risk members of our community and go and meet them where they are. And again, I think part of it is how do you also build the infrastructure? So if there is, again, some good news that comes from this pandemic, I think we've developed muscles that, again, as an industry, we may not have historically really focused on nearly as much. And some of it is ensuring that we continue to invest in the resources that we've now put in place to respond to COVID, because what we can see is that it can have an impact that is in fact long lasting. I think for me, one of the challenges is, and I know Brian and I and Kevin Sowers at Hopkins and other leaders at MHA, we've talked a lot about part of the challenge of these conversations is some of those investments are not typical return on investment timeframes that most healthcare organizations and most industries are used to. When we talk about trying to move the needle on some of these metrics, we have to do so recognizing that the timeframes we are talking about are sometimes generational. Sometimes they require, the willingness to stay the course and understand that the return that we are looking for is going to be a longer lead time than many of the typical investments that we might make within the walls of our organization. And that's sort of a cultural mindset shift. And at least for, I will say, the hospital industry, it is often a mindset shift. The good news, again, is we have learned some lessons that can serve us well as long as we continue to use the data to inform the decisions that we're going to make going forward. But it really is kind of, I think, to the question, it is how do we sustain the investments that we've made through COVID as we take on health inequity challenges that we, again, understand exist in our communities in different areas throughout the state.
Brian, this question from Nicole Stallings, who of course is with the Maryland Hospital Association, so I don't want to give this to Mohan because it'd be too much of a softball for him, but I'll send it to you because it's, I think, useful for a different perspective. She asks, with COVID, we have seen how quickly social and economic disparities can become health disparities and how that unequal system perpetuates itself. So how are anchor institutions like health plans, like hospitals, like county and state governments, how are these anchor institutions uniquely situated to improve the economic health of communities? Put differently, what is the unique responsibility of large healthcare organizations to keep in mind these social and economic health indicators in a community?
Yeah, I think it starts with the kinds of conversations we're having here, also happening in the executive leadership room and in the boardroom. And what I mean by that is that we've got to see these things not just as a social imperative, but as a business imperative. And I think the point that Dr. Dzirasa and that Mohan were making in terms of this evolution of this expanding view and how we measure success and over what period of time we measure it, we are in a moment in time where the kinds of things that we need to be investing in order to affect the trajectory of healthcare in this country, whether we are delivering care, whether we are financing care, whether we are managing experience, needs to evolve beyond just treating people when they fall ill. And so that is the conversation that organizations like ours and others are having, that this is as much a business imperative as it is a social imperative. And when you begin to have that conversation, you begin to question, what business am I in? What business am I in at CareFirst? And if I believe that my mission is to promote access and affordability, and it is, and we're a not-for-profit that is seeking to invest, and we are, then we need to begin to consider where to deploy capital, resources, and service in partnership with others in the community in a fundamentally different way than we have in the past. We also need to be willing at times to set down the things that we've historically done, to do new and different things. And so I think this is as much about a call to action around when we talk about being in the business of healthcare, what are our goals and objectives? And if we're looking to improve individual and population health, then we need to believe that we're not just in the business of sick care, we're in the business of helping to support social structures, helping to promote environmental factors that result in health and well-being. And you're seeing that. You're seeing that here locally. You're seeing that across the country. Investments in housing, housing stability, housing security, investment in job programs, investment in transportation programs to connect people with access not just to care, but also resources they need to manage quality of life over time, because people recognize that all of these things are tied up, not just in someone's health and well-being, but the economics of healthcare. And frankly, it's becoming even more of an imperative. This country is headed towards 20% of GDP, and we're pulling at opposite ends of that very big economic string. And all of that is being financed on the backs of people that are telling us we can no longer afford this. This is no longer as accessible as we need it to be. This is no longer the value that we want and need for the people that we love. And so I think that is the nature of what's shifting, DJ, in terms of the conversation. And I think all of us need to embrace that and think differently about our business models in order to respond effectively.
I think,
So
DJ,
John, please.
Yeah, can I just jump in and add and highlight something Brian said, which is, again, these conversations starting in boardrooms is actually critically important. And I would say I'm encouraged that, in fact, they have. As I've looked across not just our organization, but other healthcare organizations, healthcare executives and board leadership coming together to take on and make very purposeful decisions about where resources are going to be invested within our communities, I think is, again, demonstration of an evolution of lessons that we are learning through COVID. And that is where that value proposition is actually getting defined and how it's getting defined differently. Another critically important lesson that I think is really one that will serve us well going forward is the incredible receptivity to partnership that exists in our communities. And so when I think about community-based associations, faith-based organizations, public health leadership, legislative leaders, I honestly, if we ever were to put it down on paper and write down all the different ways we get to yes in this crisis, I think it demonstrates the strength of these partnerships. And again, I think our collective responsibility is to ensure that the same willingness that we were to figure out how to get to yes in the face of the pandemic, we take forward when we take on these same conversations around health equity issues that we know exist in all of our communities.
So Joseline.
Yeah, TJ, if I could,
Sure.
And I apologize. As Mohan was talking about this in terms of what's happening inside organizations, I think another critical element, and Joseline gave voice to this earlier, representation. If we are going to deliver and design solutions for people, it is critically important that we have representation in that process. And so what happens inside organizations isn't just about what happens in the boardroom and the executive leadership room, although that is incredibly important. It's also making sure that we've got people represented and that the community makeup is represented within these discussions, within these organizations that are participating in these solutions, so that they can be designed for the people that they intend to serve, based on differences in lived experiences and background and perspective and viewpoint and how people show up and interact with something like healthcare, which is deeply personal. And so the critical element to the health equity conversation.
And if I may, I'm
Please.
glad you said that, because I was going to go ahead and unmute myself to say that everything you said is important, both you and Mohan, but you must, when you're in a room, it is imperative to put on a racial equity lens. And you look around the room and you think, who's missing here? Who's not present? Because you need that voice, you need that experience. It is also important to think outside the box. You know that it doesn't work, that we have our differences, the cultural, right, aspect as well, and that you must try to meet us there. And you must work with partners that are trusted partners in the community, that are the voice that will be respected. You also have to have people that look like me in the community, in your boardroom as well. It is really important that we do that, and that we do things that we're not used to. But you must be creative. You go to the churches, you go to the soccer fields, you park a truck in the middle of Langley Park and bring those arms, you just have to be willing to go the extra mile if you truly want to make a difference and reduce those health disparities. You also cannot say, I support this community, that community, and that yet you don't have the documents translated into different languages, or people, when they reach a phone, they can understand them as well. We must change the way we do business. It is imperative for our health.
Letitia, maybe speak to that sort of like gap between aspiration and health sector wide awareness about how to get into communities and engage in a sustainable way that can capture long-term generational returns for the individual and the population. I sort of think of, let me sort of parenthetically add, I think of the experience of COVID in this last year for public health agencies like yours as something of a new bridge between aspiration and the current system, that now that the public health community has been working collaboratively and in partnership with the sector in ways that it hasn't been in years past, what can the public health community bring to the healthcare conversation to bring community into the fold a little more deeply? Thoughts there?
Yeah, and I mean, I think I will say that the relationships were present with the healthcare system. I think the relationships were present with the community, but they have been strengthened as we have come together to address COVID collectively, right? So when I think about one of the things that has been the most impressive, it's how we've all been able to come together. But I think it's because we have this common mission, and everyone has touched on the importance of us all speaking with the same voice as we kind of all fight the same fight. And I think that's been critical to a lot of the success. We've really deepened our relationship with community-based organizations. Again, I think they were there, but we knew early on this wasn't something a health department could take on by itself, right? It would have to be in conjunction with partners, in conjunction with other city agencies, in conjunction with community-based organizations who are the trusted voice and the messenger, oftentimes when the government isn't. So we early on established, leads that are liaising with our community-based organizations. So having unique leads for every what we've called value community. So for our Latinx community, there's an internal lead who worked with external partners. For our immigrant refugee population, which we are considering separate from our Latinx community, there's another lead. For our pediatric population, we'll have another lead. So I think really digging deep, what we've heard is that, I think as everyone's mentioned, the community doesn't just want you to come in because you're giving a shot or because you're testing. They really want you to be invested, and they want to know that you are genuinely invested in their health and long-term outcomes. And that's how you build relationships, and I think really engage the community in a way that will be most effective.
We're getting near to the end of our song and dance here, so to speak. I want to give each of you an opportunity to talk about what gives you hope, what makes you feel good, what excites you about healthcare, health policy, and just being alive in 2021. So Joseline, Delegate Peña-Melnyk, let's start with you. What gives you hope about being alive and working on healthcare in 2021?
What gives me hope is the conversation that we just had with people that are like the people that are on this panel. We all know that we have the health disparities. We are discussing it. We are accepting that public health, racism is a public health crisis, and that we're ready to roll our sleeves and work. And I feel very hopeful. And I'm ready. I'm ready to work and ready to work with all the partners that are on this call.
Mohan, how about you? What gives you hope?
So I think maybe playing off something Joseline said, I think for us as an organization, the hope that I have is shaped by the culture that we are evolving as an organization. And sort of as we think about and define what it means to be an anchor institution and an anchor organization within our communities, understanding the vibrant role that we play outside the walls of our organizations as active members of the community, recognizing that the responsibilities that come with that. What gives me hope is the way our organization has embraced that cultural evolution. The other thing that I would say gives me hope is science, because as a physician, as a leader, I think when we think about how we have navigated this this pandemic collectively, I think when we've allowed science and data to rule our decision making and rule our conversations and help inform how we bring science forward, we've succeeded. And I think we've just got to continue to let science and data inform our conversations. And with that, we will continue to see the successes that we're starting to see.
Letitia, how about you? What gives you hope here in May of 2021?
I think the thing that gives me hope is, again, conversations like this, because the pandemic has really shown a light on, I think, what a lot of folks already knew about the social determinants of health and how we have to come together to address them. And it's placed public health in the spotlight, for better or for worse. But it also, I think, allows public health to have a voice as we think about legislative changes that need to happen, things that might not traditionally have been considered a health issue. Now we're looking at it through a lens of health equity, and that's huge, right? And that's not something I think that public health was asked to do before. So just the fact that we now have this voice and can speak gives me a lot of hope.
Brian, we'll give you the last word. What gives you hope in May of 2021?
I would say what gives me hope is that this feels different. It feels different to me. In the 25 years that I've been in healthcare, I think to Letitia's point, we are aware of, right? We know what the data tells us relative to inequity, and we've seen it, frankly, since the dawn of the healthcare system in the United States. But this moment feels different because it feels like we are seeing it with a degree of clarity and with a degree of urgency and more universally and more plainly as a society than we've ever seen it before. And it feels like people are looking at this and saying, this is wrong. And this needs to change, and it will change because we act. The other thing that I would say gives me hope is that I look at this panel and I see people that I know are personally and professionally committed to impact. People that not just during these panel conversations, but in private conversations and in the work that they do every single day, have this as one of their primary objectives, one of the things that they view as a strategic imperative for their organizations, not just as a social imperative. And I think when we've got people that are willing, that coalition of the willing who are in a position to act and marshal resources against the backdrop of a shifting expectation within society, there's nothing that we can't accomplish. And so we can do this. We can do this together. We absolutely need to be committed to sustaining the work beyond just the current moment. But I believe we've got the right kind of leadership in the right places to accomplish that.
Brian Pieninck, the CEO of CareFirst BlueCross BlueSheild, Dr. Mohan Suntha, the President and Chief Executive Officer of University of Maryland Medical System, Delegate Joseline Peña-Melnyk, the Vice Chair of House Health and Government Operations Committee, and last but certainly not least, Dr. Letitia Dzirasa, the Commissioner of Baltimore City Health Department.